Hi, everybody. My name is Mark Dunning. I am a rather tall white guy wearing a blue checkered shirt and a blue jacket. I do want to just add one quick thing to give you some perspective on what Jen Lentz just talked about. When I stood up here 10 years ago, none of this stuff was happening. We didn't even have most of these animal models. So I know it feels like the research is slow, but we have come a long, long way, and this stuff is coming, so hang in there. I do need to say one thing. I told Dominique Sturz, who is watching online in Austria, that I would say hi. So hi, Dominique. I should probably also say hi to my dad, who's also watching. So it is my pleasure to introduce Dr. Margaret Kenna, who has been on the otolaryngology faculty at Boston Children's Hospital since 1995, even though she's only like 25 years old, which is pretty impressive. She co-founded the BCH cochlear implant program and was its director for several years. Since 2003, she's been the director of clinical research and is also the director of the hearing loss program at Children's Hospital. She's a graduate from the University of Pennsylvania and Boston University. She lived for a while in Arkansas, which I remember, and also in Pittsburgh. But none of that really matters. What really matters to you is that she was one of the founders of the Usher Syndrome Coalition. She has been instrumental in helping to organize the researchers, and a lot of the stuff that you see happening in research these days is happening because of the help of Margaret Kenna. She is also a former winner of the Foresight Award. Congratulations, Carmen. And she's also been a great friend to me, even though I was just one of the dumb dads who happened to have a kid with Usher syndrome. So it's my great pleasure to introduce Dr. Margaret Kenna.
Thank you very much. I am really pleased to be here, and I have to say, I've learned a lot from the dumb dads like Mark and moms and many of you in this room, and I'm so lucky to be here. I'm a pediatric ear, nose, and throat doctor at Boston Children's. I run the hearing loss program, and that's how I became involved in Usher syndrome. Just so you guys know what I look like, I am a slightly older than middle-aged white woman with glasses and brown hair that's going gray, and what can you do, right? And I'm wearing green. I probably should have been wearing black, but I look really bad in black. So I'm going to talk a little bit about atypical Usher syndrome and whether it's Usher syndrome type 4. And before I get any farther, I want to thank the coalition and Krista and Julia and everybody that made this meeting possible. I've been at lots of them, and it's just so empowering and exciting to be here, so I don't want to forget to say all that. Thanks. So I'm a ear, nose, and throat doctor. I sit in clinic. I see lots of patients. I see lots of babies and young children diagnosed with hearing loss. And when I was coming along, hearing loss was what we did. We thought Usher syndrome was even rarer than it is now, that we know it is now. And we never saw anybody in clinic because the vision part was diagnosed later, and it was diagnosed in ophthalmology. And so then we started to see kids fail their newborn hearing screen. We diagnosed their hearing loss, and then I got really interested in genetics, and that's how this came about. So now we see very young children with a diagnosis of Usher syndrome. But now there's a large spectrum of genes, and that's what I'm going to talk about. I have nothing to disclose. As I say at all of my ear, nose, and throat meetings, studying kids with hearing loss is a really bad way to make money. So Jen Lentz really outlined very nicely, and I think all of you guys are aware what Usher syndrome is, but it has a lot to do with whether this is atypical or there are other genes and stuff like that. So it's the most common, as you know, genetic cause of combined deafness, blindness, and balance impairment. It was first described actually in 1858, which was before Alexander Graham Bell had the telephone, by a German ophthalmologist who had 3 brothers. They all had hearing loss and vision impairment, and then one of his students figured out that it might be recessive, and it might be genetic. But it was a long time, decades later, when that guy, the ophthalmologist in Scotland, Dr. Usher, actually coined the term, and it was named after him, and he had described 63 patients who had a clinical diagnosis of Usher syndrome, but of course there was no genetics. This is why it's so hard to figure this out. So this is Gregor Mendel, this guy here. He was a monk. He studied peas, and he figured out that there was a genetic way that traits were handed down. He looked at color and flower shape and stem length and all this stuff, which sounds like you can't believe it, but he's one of the founders, maybe the founder of the genetics field. And so he was there at the same time as these initial people identified Usher syndrome, and they probably, maybe, had some crossover. He published a paper in 1865 talking about the inheritance traits in peas. So that's pretty much what we knew in the 1800s, and then Dr. Usher in 1914, and then there was a description clinically of these three types of Usher syndrome that Dr. Lentz beautifully outlined, and until we had good genetics, people tried to fit into one of these categories. And everybody said, well, I have these symptoms, I'm in Usher 1. I have these symptoms, I'm in Usher 2. I have these symptoms, I'm in Usher 3. But it turns out, because we can do the genetics now, there's a huge amount of crossover between all three of these. So these are the genes that we know are related to Usher syndrome. There are 9 of them, and Dr. Lentz outlined these. They all talk to each other. So in the eye and in the ear, in the cochlea, in the hair cells, in the supporting cells, and in the photoreceptors in the eye, they actually all talk to each other in something called an Usher interactome. And that has a lot to do with trying to figure out whether somebody actually has Usher syndrome or not, because if they have one of these genes and they have vision and hearing impairment, maybe vestibular loss, then probably that's what they have. Why does it matter if we figure this out or not? Well, it matters because, as Dr. Lentz outlined, and as Dr. Holt coming behind me will also talk about in the afternoon, researchers, if you know what the gene is and you know what the change in that gene is, and these are giant genes, so in some genes there are a couple of common variations, but in some genes there are hundreds, and you might have your own private change. So it makes it hard to design therapies and to have a real definite diagnosis of this disease. And then, so the natural history studies, as we talked about, for each gene are really important as a basis, so we know where people start when they start with gene therapy or a small molecule therapy or whatever's going to come along to help people with their vision and their balance and their hearing loss. If it's not certain, if you do an initial genetic test and it's not certain, then you maybe should keep looking. There's a reason that if you do find an accurate diagnosis, that perhaps that will impact having other children in your family, or maybe your sibling's going to have children, or you're just going to tell your friends about this as a possibility. So they will get tested and they will be able to figure out for themselves what they want to do with this information. The other great thing about this is you get to hang out here at this meeting with great people like us if you think you have Usher syndrome or something that looks like Usher syndrome. So that's a very good thing to do. So as we talked about, this is a recessive disease. It means that each parent, biological parent, or sperm donor, or whoever you got their genes from, each copy forms a child, and the child has 2 copies, and historically they then have Usher syndrome. The problem is that some of these genes have variations that only have hearing loss, and some of them only have retinitis pigmentosa, and there's a handful that are not recessive, they're dominant. And so, example, myosin 7A, which is Usher 1B, as you all know, there are some dominant variants in this gene that cause only hearing loss. So when the patient comes to see us or sees genetics and they say, okay, these are my mutations or these are my variations, what do you think? It's so important and sometimes so hard to say, especially if the child in front of you is 4 weeks old, to say how this is going to go down the road. If you have other people who have that same variation, if we can find it in the literature, we can find it in these large databases, we'll find it like calling people up from the Usher Trust. We'll look for other people who have these same variations, and then we'll look to see how they've done and what's happened with their trajectory and their journey. And then we can say to this 4-week-old baby, this is maybe how it's going to go. But a lot of people have what are called de novo mutations. You're the first person to have it, and it's never been described before. And so it's really hard in a very young child especially to say, you know what, we're worried about this, we think this could be this, but we're not sure. The other thing is that the clinical presentation, as Dr. Lentz mentioned, is very atypical. So it used to be that the people who had only the most obvious symptoms, hearing loss, vision impairment, balance impairment, got tested. And they were part of the first studies that identified all of these genes. But now we can test everybody. And we can find out there are people who do have a severe form of all these symptoms, but we may find people who say they have myosin 7A mutations, but they look like USH1B, but their clinical presentation is USH2. They have a lot more hearing, they benefit from hearing aids, they sort of walked on time, and their clinical vision is normal. So we have this wide range of presentations, and I don't know if we call that atypical, or we just call that what's called a phenotype, the clinical presentation of the genotype. It's just bigger, and we're learning a lot more about what are considered the standard genes. The age of onset of all of these things can vary a little bit, as Jen mentioned. And the other thing is that genetic testing, as I just said, is not straightforward. I'm sure there are genes we don't know about. The interpretation of the genes can be inconclusive. Maybe you only have one copy of what's considered an Usher gene, and you can't find the second copy. So does that mean you don't have a second copy? Or does it just mean the test that you had done isn't good enough yet to find that second copy? And that's something we work on in our lab and many other labs, looking, if we did this test, didn't work, we'll go to this test. It didn't work, we'll go to this test, and maybe down here we'll figure it out. Or maybe it's something else. So there are a lot of other genes, if you read the literature, and I'm sure many of you are familiar with this, that are initially thought to be Usher syndrome genes. Well, it depends a little bit on the definition of Usher syndrome. If we say that the definition is sensorineural hearing loss, either at birth or later, depending on your gene, balance impairment, if you have it, and retinitis pigmentosa with variable times of onset of the clinical vision loss, we can actually detect the retinal degeneration very early with electroretinography in many cases. But that's not something everybody does. But there are these genes that I've listed here that maybe actually turn out not to be Usher syndrome genes. They're something, but not Usher syndrome. So PDZD7 just rolls right off your tongue. Probably is a modifier gene, maybe, but it's not an Usher gene. ABHD12 actually causes something else called FARC. It stands for polyneuropathy, retinitis pigmentosa, some hearing loss. But they also have cataracts, and they may have other things. So it's a different syndrome, but not Usher syndrome. The next couple, CIB2 and ESPN, probably are only hearing loss genes. And then HARS, which people have called Usher 3B, has only been described in one family. It was described in a large old order Amish population. That's a population that is very much keeps to themselves genetically, so there's a lot of consanguinity, and the genes reproduce within the population. But that one patient had a lot of other genes, and they had a lot of other symptoms that nobody with Usher 3 has. So it may not be an Usher gene at all. And then we get to the SEP genes, which are genes in what's called the centriole, has to do with sort of stereocilia, and SEP78 and SEP250, I know people have asked about this. They do present usually with later onset hearing loss, but they also have something called not rod cone dystrophy, which is the two sets of cells that are affected in Usher syndrome. The rods tend to be affected first, and you get peripheral vision loss, and you have trouble in dim light, and your central vision and color vision is preserved often for a long time. This is the flip of that. This is called cone rod dystrophy. We may have a little more trouble with color vision and central vision, and then the peripheral vision starts to go. So the question is that Usher syndrome, or is that something else that affects hearing and vision impairment, but not Usher syndrome? And then there is this new gene that people have called Usher syndrome type 4. It's called ARSG. It's a later onset hearing loss. It's a later onset retinitis pigmentosa, and it's progressive hearing loss. The problem with this gene is that it doesn't interact with all the other genes in the Usher genes. So the question is it an Usher gene, or is it just something else that affects, again, vision and hearing, but it doesn't, it's not an Usher gene. So this is a picture of why we see hearing loss and vision impairment. On your left is a photoreceptor cell in the eye that's affected by the genes, and on the right is a hair cell in the inner ear. And if you look, you can see where all these different genes interact, and they show up at different times in the development of these cells, but they interact with each other in both the photoreceptors and in the inner ear. So, as I said, maybe this is a problem with the definition of Usher syndrome. So this is a bicycle, and we all know bicycles have two wheels. Most bicycles look like this. And if I say bicycle, this is probably what pops up into your brain. So here's the problem. These are also all bicycles. And I'm sorry if some of these are a little small, but all these bicycles have two wheels, but a lot of them don't really look like bicycles. And so the question is, are they still bicycles? Or are they something else that's related to bicycles? And so to me, in thinking about the definition of Usher syndrome, this is what I'm thinking about. How do we define it? And is it a big tent and we bring everybody in? Or is it a smaller tent and define just these Usher genes that we know about, and then these other things go down slightly different pathways? Or is it something else? And we certainly see people who are thought to have Usher syndrome who actually have never been tested, and they have vision impairment because they were extremely premature. They had congenital rubella or congenital CMV, which is a virus that can affect hearing and vision, an in utero virus. Could it be some other syndrome? There are lots of syndromes that have to do with vision loss and hearing loss. The two that we see all the time are Charge syndrome and Stickler syndrome. And so although the hearing loss in those look kind of similar, the vision impairment is very different, but unless you're looking genetically, you may not figure it out. And has someone actually measured all of these things? I mean, we see people where they say they have something because they've had some genetic testing, but in fact they don't have hearing loss, or they don't have vision loss, or they don't have anything. They've had a genetic test for some other reason, and they picked up a single mutation, which actually means they're a carrier and they don't have a syndrome at all. And you look at this to see if they have any other clinical features that might clue you in. So basically, in summary, because of much more available genetic testing and increased awareness of Usher syndrome, we're seeing many more patients who actually have this. We're seeing them much younger. The atypical presentations may really just represent, in many cases, a wider spectrum because we have better testing. All deaf-blindness probably is actually not Usher syndrome, although it's clearly important to figure out what's going on. There probably are new Usher genes. Whether these genes I talked about today or not are them, I'm not sure, but there certainly might be other things. The definition of Usher probably will evolve as we talk about this wider spectrum of presentations. And the reason that we want to know this stuff is because of all of you guys. We want to know what's going on, what to do to help everybody. You come to us as physicians and researchers with really good questions that we can't answer, and I'm like, okay, now I need to know. So it's super important that we get and have the privilege of working with all you guys. Thank you so much.